Dear friends and colleagues, today I'm going to share with you one of my cases. We have missing first mandibular molar, and we are going to extract the second mandibular molar and replace it with immediate implant. Clinically, we have mobility in the second mandibular molar, and radiographically there is radiolucency around the second molar. The decision was to make extraction and make immediate implant placement. In such a condition, I prefer always to make the incision and the reflection of the flap before starting the extraction to avoid any tissue laceration. You can use the inferior nerve block anesthesia or the infiltration anesthesia. I prefer to use the infiltration anesthesia in such a condition to be sure that you are away from the inferior alveolar canal. With the infiltration anesthesia, if you are close to the canal, the patient will start pain and you can stop. You can put a guiding pin and make a periapical X-ray to be sure. Incision and reflection, and use any desirable forceps according to what is convenient for you for the extraction. After the extraction, we should make proper bony curettage to remove the granulation tissue. According to the bone defect, you can decide either to put the implant at the bifurcation area using any method for bone expansion, or to put the implant at the mesial or the distal root area according to which has more bone around. The most important thing that when you put the implant, you should have adequate initial stability. Following the implant surgical protocol, we make the osteotomy using the initial drill, then gradually increase the size of the osteotomy site corresponding to the diameter of the implant that we are going to use. In this case, we plan to put 4 millimeter diameter implant at the site of the first molar, while we are going to use 4.5 millimeter implant at the site of the second molar. Of course, we are going to make bone augmentation for the socket and to make augmentation for the bone resorption area around the second molar. Sometimes we need to soften the membrane. Then, after we put the cover screw, and to fix the membrane in place, we can use either bone tack or bone screw, or simply we can use a simple way to use the rubber dam punch to make a hole in the membrane corresponding to the cover screw area. I prefer always to put the cover screw before inserting the bone graft in place. After that, we can remove the cover screw and use it for fixation of the membrane. I usually put the cover screw to avoid the entrance of the bone graft particles inside the implant. So I prefer always to put it first. Then after packing the bone graft, we remove it and fix the membrane. According to the bone graft particle size, I prefer to use large size of bone graft granules so that we have enough blood supply for the bone granules or the bone graft granules. Also, while the packing, we avoid overpacking of the bone graft. We use gentle condensation force. After that, we remove the cover screw. Put the membrane in place and reinsert the cover screw again to fix the membrane in place. Of course, we still can use the bone tack or the bone screws, but as we are going to use a collagen membrane, no need to go for re-entry to remove the membrane, and no need to use any material which needs a re-entry to remove. The disadvantage of this technique that the cover screw and this area is little bit loose because of the thickness of the membrane. Here we can nicely adapt the membrane in place, then suturing the flap. I prefer to use the tissue forceps to hold the mucosa, not to remove the membrane from its place. And here we have the final closure of the case. Please, if you have any questions, do not hesitate to contact me through the YouTube site or using my email. Here is the pre-operative and the post-operative, and we can see here that we have enough space between the implant and the inferior alveolar canal. Thank you very much. Hope to see you soon.